The members of the ACIP had the additional participation of what are called liaison representatives, representatives from a variety of professional communities, the American Academy of Pediatrics, the American Academy of Family Physicians, others, who could participate with their wisdom and knowledge about vaccines, but didn't vote. But the whole discussion was enriched in that fashion. Those persons have now been excluded from the discussion, and we're not getting scientifically unbiased, rigorous presentations before the committee. I'm profoundly sad to say.
Welcome to Health Beat, a medical news podcast series from MJH Life Sciences. I'm your host, Kevin Kunzmann. Today we'll be discussing the much-anticipated first meeting of the CDC's Vaccine Advisory Committee with my colleague John Parkinson from ContagionLive.com. We'll also be featuring our interview with Dr. Robert Hopkins from the National Foundation for Infectious Diseases. For decades, the CDC's Advisory Committee on Immunization Practices, better known as ACIP, has played a central role in shaping vaccine policy in the United States. The committee reviews clinical evidence, they debate safety and effectiveness, and they ultimately issue recommendations that guide the national immunization schedule and influence insurance coverage for vaccines across the country. But as ACIP prepares to convene for its first meeting of 2026 later this week, the committee finds itself at the center of unusual scrutiny. A series of recent personnel changes, including the new appointments and leadership shifts at the CDC, has raised questions about how the committee may approach vaccine recommendations going forward. At the same time, public health officials are responding to ongoing measles outbreaks and renewed concern over the declining vaccination rates in the country. Today, we're taking a closer look at how ACIP operates, what changed in recent weeks, and what clinicians should watch for as the committee meets again. I'm joined now by my colleague John Parkinson, who has been covering this topic for Contagion since the summer of 2020, when nothing else was really going on. John, how are you doing?
Doing well, Kevin. Thank you for having me on the show.
Thank you, John. I really appreciate having you on. Obviously, we've talked to death over the years. All of the major structural changes, policy strategies, and shifting sentiments around vaccination as it relates to major subjects in public health, COVID, of course, now measles, everything in between. It's been pretty implicative, but honing in now really today around personnel and exactly the setting that we find ourselves in with the ACIP's operation under this administration is morbidly interesting, I guess we could say. So let's start at the fact that ACIP has historically been one of the most influential bodies in U.S. vaccine policy, as we said up top. Why are so many people watching this upcoming meeting on Wednesday?
Absolutely. So I would say that this meeting is going to focus on the COVID-19 vaccines, including the vaccine's efficacy, its safety, and long COVID, which is something that really hasn't been discussed before. So that'll be interesting to see what happens there. But I think one of the big things about this ACIP that we're going to see is what type of data are they going to present around the COVID-19 vaccines and really what their talking points are. I think this is important to see if the committee will recommend making changes to the current COVID-19 vaccines, much like they've been doing with the other vaccines. The concerns are that the vaccines might be made less accessible.
Right, of course. And of course, this is a trend that we've been seeing, unfortunately, across the board, again, under RFK Jr.'s, newly minted HHS system. This is not our first rodeo, as I alluded to before. We are covering COVID-19 since essentially the launch of the pandemic all the way through to this point, and still in some ways still are covering. But for those who are tuning in maybe for the first time or just trying to become more attenuated with what's going on with the ACIP, what should they expect for Wednesday in terms of the agenda, the structure, the flow of conversation and deliberation?
Absolutely. So the meetings are typically, they have the agenda. They will publish that. It hasn't been published as of our filming right now. But the meetings are typically all-day, 2-day events. And then you have the FDA, CDC, and the pharmaceutical manufacturers who are making presentations around data of the vaccines. Now, typically, this is done with newer vaccines that are FDA newly approved by the FDA, or they are about to be approved. So this is a little different because what you're having here is ACIP meeting to discuss existing FDA-approved vaccines that have already gone through this process. So they're renewing this process, so to speak. So it's going to be interesting, but typically what will happen is the data will be presented, and then after the data is presented, they'll typically have a couple of votes around the vaccine itself. Now, again, we're not privy to that information yet, but on the day of the meeting, they will present what the voting language will be. And then the ACIP voting members will make that vote.
And of course, as you're alluding to, we do not have information really available around the agenda, which I think is sort of stoking some of the flaming sentiment that we have right now around what is going on here, the heightened scrutiny around this group. We're going to talk a little bit about the personnel changes, the additions, that it looks like in just a moment. But just to ask you sort of broadly, because we want to get these sort of content-y, grabby, headline-y level questions out there, is this the most scrutiny that the committee has faced in at least the last decade? Because that's a pretty high bar. Absolutely.
And I would say it is so, at least in the 5.5, almost 6 years that I've been covering the ACIP meetings. Certainly, I think there are concerns around the qualifications of some of the committee members and their public stances on vaccines. We went from a time where you and I were both covering these almost 6 years ago, around 6 years ago. We had a committee talking about the authorization and the potential approval of newer mRNA COVID-19 vaccines, which at that point had never been done. And then more recently, with the RSV vaccines, which have been approved in the last couple of years, in reducing access to vaccines. So we've really kind of done an about face, if you will, going from newer products to, again, looking at already approved vaccines. So it's going to be a little different that way. It has been a little different in the few meetings that the ACIP meeting under Kennedy has had thus far.
Well, the previous advisory committee on immunization practices used two very rigorous procedures. First, they did something called the grade assessment of the quality of the evidence. So they looked at all the information related to the vaccine. The same information and perhaps more had been accumulated that had been presented to the Food and Drug Administration. So all the information about effectiveness and safety of the vaccine. They then moved to an evidence to recommendations framework in which they assess critically and objectively the extent of the public health problem, the risks and benefits, vaccines benefit and safety, the feasibility, the acceptability, the cost effectiveness, and the equity of the possible recommendations that are being presented. It's all done in an open, transparent fashion, in a rigorous fashion. That was the previous ACIP. The current ACIP isn't following any of those.
These new appointments that we're talking about, obviously two new additions to the committee itself, and as well to acknowledge that we have a new acting director of the CDC after an ousting earlier this year. These new appointments, does it really change the expertise of perspective represented by the committee at all? Because I know that was sort of a selling point, that they're adding relevant perspective to this.
I think it does. And the reason why I say that is last June, HHS Secretary Robert Kennedy dismissed the 17 voting members of the committee, and he replaced all of them.
Right.
When you look at their bios and you see everything from their social media to the books they've written to different interviews they've done, these are vaccine skeptics and have been vocal about their opinions. So there is an ideology around vaccines that exists on the committee. So I would definitely say, they just brought in two new ACIP members. Both, I believe, are pediatricians.
Right.
Not really much is known at this point. So it'll be interesting to see, as this is going to be their first ACIP meeting that they're going to be attending and voting in.
Right. It's been very difficult to gain a sense of the trend in development in this space, it seems of late. It seems like every new addition. To be very frank, this administration's highly volatile. We saw this from years ago as well, of a lot of ins and outs of who's leading what, who's the head of what chair, and what is their role and dynamic. And it seems like Dr. Jay Bhattacharya, who's now acting director, has sort of helped provide at least a level resolve. And we've heard some positive feedback from infectious disease specialists and experts, at least relative to what was previously operating as the standard for the CDC at the moment. It is really interesting to look at this situation now, as you're alluding to, the two primary care, two family medicine-based physicians, not really even being sure, because we don't have an agenda of what should we be expecting from them. What are their priorities going to be? Are they going to be I guess, what some critics would say, the adults in the room, or are they going to be contributing to this growing scrutiny around our currently available vaccines?
Absolutely. Some really good points there. And I think that's one of the things that's a little bit challenging right now is if you look at medical science, they very much like to know people in the field of exactly which way we're going to go. I don't think they like the idea of us being in this position where it's uncertainty. And for lack of a better term, maybe chaos in some ways, because we're just not sure. And what is one decision today might be a different decision tomorrow or next week.
Right. And consistency is very key, and regiment. And obviously, we've been accumulating tons of feedback at every turn with all these different changes. At points, it is a little hard to keep up with it because there's just, as we're describing, so many different developments. But could we pinpoint some of the perspective you have been collecting from folks in the field, our vaccinologists, our infectious disease experts and specialists? How are they feeling about everything that's been going on? What are you hearing for feedback?
Absolutely. So I had a chance to moderate a roundtable recently with some well-known names, including Dr. William Schaffner, Dr. Sharon Nachman, Mary Patrico, and Dr. Jacinda Abdul Mudakabir. And they all come from the infectious disease space, and everybody from pediatricians to internists to pharmacists. And they all have really kind of a, if you will, a common theme, which is this idea that we don't know what's coming. And again, I think it leads to the challenge of not knowing is not good for this particular field. And especially when you're thinking about everything in terms of what they have to do for their particular responsibilities, and then in turn for the families and the individuals they're caring for, that makes it really problematic, because if you're getting confusing guidance from your federal government and people that are the experts, and you're trying to disseminate that and figure out what should I be telling my patients, that becomes very difficult.
Maybe we just jump ahead to talking about sort of the impacts of this short-term in nature decision-making and the cascading effects it has in the entire relation of the public health scale. We're talking about vaccinology. We're talking about managing, mitigating global-borne disease at turns here. This is not as simple as an on-off switch. It has effects that we don't see finish rippling for months on end, years on end, to some extent, some of these deliberations that the ACIP group is charged with doing. What long-term impacts are we really nervous about here?
And I alluded to it a little bit before, which is this idea of confusion, I think. And then ultimately, it's going to be decreased vaccine uptake across the board. We're talking pediatrics, we're talking adult vaccines. And as it's been said to me by clinicians, if individuals or families don't feel vaccinations are needed, they're not going to get them.
Yeah.
There is not any data to really support these changes. And I think that even with there not being any data to support the change, it's actually data to the point that the decisions likely aren't the best for us to make. So we have data that really point to that otherwise. And I think that the talented and those that, like I said, I stand on the shoulders of those that come before me, especially when it comes to treating these diseases. I, at the younger age of my early 30s, had not seen most of these diseases before, especially when it comes down to polio and measles and so on. And I think that that's the evidence to the otherwise. I have not seen these because we have had vaccinations. We've had folks that have seen the impacts of these diseases, spent time, either treating folks with an iron lung or spent time in the iron lung themselves, and they know how detrimental that is. The short answer, and I hope that this, is fine to say, is that there is not any data, for the otherwise. It's really kind of a motivation of, well, we don't see it. Because we don't see it, then, there's no need to continue to vaccinate against it.
The Yale School of Public Health recently did a modeling analysis that showed a sustained 1% annual decline in the measles, mumps, and rubella vaccine could lead to more than 17,000 measles cases, 4,000 hospitalizations, and 36 preventable deaths each year.
And that's mostly children, I would acknowledge.
Correct.
Yeah.
Correct. And the analysis also predicted that over the next 5 years, the declining measles vaccination rates could cost $1.5 billion annually and add an approximately $7.8 billion in cumulative costs.
And again, that's from 1% change. Yeah.
Absolutely. And we're just talking about, if you really think about measles, mumps, and rubella, the one that has the greatest impact right now would be measles, but those others would come back as well. So thinking about the impact of just taking away that one vaccine, but not even talking about the other ones. There's been the extreme dialogue about looking at polio and whether that is something that people should make their own choices on. So I think that is definitely another challenge, is this idea that it could have a cascading effect across the board. We haven't really touched on RSV or even looking at the COVID-19 vaccines with the ACIP meeting coming up. If you make them more restrictive and you have this public confusion that people don't need these, you're going to have, again, more sickness in the very young and vulnerable and the older senior populations. And again, you'll see more mortality, more morbidity, and just the healthcare costs.
This feels very reiterative to the conversation I had with our colleague Matt Hoffman in the first episode of Health Beat when we were talking about the measles outbreak, which really began in 2025, but was beginning to stand out, especially at the very first few weeks of January 2026. And a lot of the conversation there also, raised to criticism some of the sentiments that Robert F. Kennedy Jr. was, espousing misinformation around the measles vaccine and its impact on patients and potential health risks, on cable news channels and really just broadcasting as part of his greater public health messaging as a leader of the HHS. What other issues are experts raising around these claims of data evidencing that these vaccines are not beneficial? What exactly are the ID experts pointing to as this is something we need to nip in the bud and address as misinformation around the vaccines?
The biggest thing that they've said to me, it's about counseling people and meeting people where they are, because there is so much misinformation, and even more damaging is disinformation. And I think it's important to point out the two. So disinformation, as it's been explained to me, by a clinician, is that it's knowingly sending out something that you know to be false. Misinformation is maybe posting something on social media, but you don't really know the validity behind the message. Yeah. So there may not be something where you're purposely doing that, but it may be just something you agree with. Yeah. So clinicians have said these are some of the things that they're battling. Yeah. And so what they really want to do is meet people where they are with the information that they have and slowly bring them along and make them understand why there is the value of the vaccines and try to understand what their feelings are about the vaccines so that they're not just making people feel like this is good for you, you need to take it, and that's it.
That was a huge sentiment I think we both saw from covering the pandemic for Contagion Live back in 2020 into 2021 when the vaccines began to become more available for the public, was this earnest grassroots effort at the individual and institutional scale by most clinicians, caregivers, experts, advocates for it, trying to meet people where they are, as you so aptly described. Returning a little bit to the ACIP meeting, which again, we have no agenda. We don't have much preempt. It sort of feels like going to see a scary movie without even seeing the trailer. Just don't know what's going to jump out there. But there's some discussion and some inklings around revising the way ACIP evaluates vaccine recommendations. Do we know what that might look like or what the sentiment is around that?
Yeah, absolutely. One of the things that the federal agencies has moved away from is this idea of universal vaccination and embraced shared decision-making between individuals or families and their clinicians. So this is a massive shift, really. Clinicians will tell you that they've always done this, where they're talking about shared decision-making. They always have conversations with the families and individuals about why these vaccines are important. So the ACIP and the federal agencies are using this as a way to say, hey, look, we're giving people the power of choice. And the other thing that they're really looking at is they're looking at reviewing approved vaccines, as we had mentioned at the top of our conversation, and potentially adapting European standards. One thing that came out recently is the HHS, in a statement, they mentioned that the country of Denmark vaccinates for 10 diseases. Prior to the changes in the U.S., which had 17 vaccines for universal immunization, it's now down to 11. They didn't mention that Denmark is not only a much smaller population overall, but it has universal health care that has people from the time they're babies all the way through adulthood being seen by doctors. And then also it's the idea here that it's a homogeneous population mostly. So all these factors can play a really big deal in terms of the types of diseases that country is seeing.
You know, it reminds me of, again, during COVID, during the initial outbreaks, we highlighted some countries and nations, including New Zealand, as doing such an excellent job of maintaining and mitigating the spread and being able to manage their cases. New Zealand, population of about 5 million people, I think at the time, maybe the most isolated nation of that size, aside from, say, Japan, out in the Pacific Ocean. So obviously some fortunate circumstances that while the U.S. could look at as emulative of embracing public health strategies, copy-pasting that methodology into such a, as you're describing, diverse and massive population as ours would lead to critical failure. And that's just, to be honest, great for Denmark, not great for us. That's not a model for us.
Absolutely. And we're starting to slowly see those cascading effects. And, you know, whether it's what we're seeing as far as the measles incidence rates right now, what can be happening in the long term. I had a chance to speak with Dr. Sharon Nachman, and she talked about one of the things that there are things that are going to happen sooner in the vaccine roundtable that I had mentioned earlier. There are things like the rotavirus. If you stop giving the rotavirus, it could very quickly turn into something where maybe next spring or the following spring, you start to see cases go up. That's where its peak time is. And then long term, if you have less people getting vaccinated, less children and babies getting vaccinated for hepatitis B, in 15, 20, 25 years from now, you could see a large increase in cases just based off the fact that a lot of these kids won't even know by the time they're adults if they got the hepatitis B vaccine. And it is one of those silent killers and types of things that doesn't always present. You don't have a lot of symptoms. So you could be silently carrying around what could be a very deadly disease or at least a chronic disease that could cause you many things, including liver cancer and the need to get a transplant.
The most important issue is the deferment. That message of deferment tells families, you don't need it now, and I don't know that you need it later, and I don't know when you need it. So we are going to see children who do not get the birth dose, whose mothers are truly not infected with hepatitis B, so their risk at birth of acquiring it is zero or close to zero. But if they don't get the vaccine at 2 months or at 2 years or some other time, they're going to grow up to be adolescents and adults with no memory that they've never gotten this vaccine. They're going on to have behaviors that may include some risk, and they're going to acquire this infection, which is silent, at an age when they're quite vulnerable, and get chronic active hepatitis B, a disease that we could have easily prevented. So it's not so much for the infant whose mother is 100% status known and zero risk. You could defer those to 2 months or 4 months or 6 months. But for those whose mothers we don't know, or for those who are going to have risk behaviors 20, 30 years in the future, we've missed the opportunity to give them lifelong protection.
It's like death by icicle. The evidence melts away and you're not sure what exactly happened and the cause or how you can resolve it. It's a very scary thought of just, again, short-term solutions and strategies with lack of any context to the long-term impacts of just future generations. So even if we were to able to turn the switches back on and make course corrections on some of these decisions immediately today, as you're describing, we could still see effects a year to 10 years down the line from just what happened already. So unfortunately, something for us to monitor, but one thing at a time on contagionlive.com. You got an ACIP meeting that you don't have an agenda for, but high stakes to cover on Wednesday. How exactly are you hoping to approach the meeting itself for coverage, and what are you hoping to follow up to inform the audience on after?
Absolutely. So what we're planning to do is I'm going to be covering the meeting myself remotely. They air all the meetings, so that's great for us. So we're able to watch in on the proceedings. So we'll make sure every day at the end of the day, when the meeting's over, we'll highlight that through some reporting. And then on Thursday, at the end of the second day of the proceedings, we're going to be talking to Dr. Nachman in a YouTube live video feed, which is going to be great. This is going to be a new venture for us, but it's going to be interesting to hear her feedback in terms of what we're looking at and how this will affect people and the decisions that are going to be made. Because again, they have to go through the vote, and then the decision will be made through CDC and HHS, and then we'll see what happens with the COVID-19 vaccines in the near future.
Was there anything else you wanted to add, though, relative to what we talked about?
Yeah, I think it's important, if I could. The one thing I wanted to point out, and I know I've been referencing the hepatitis B vaccine,
Sure.
and I wanted to use that as an example because the previous recommendation prior to ACIP's moves and HHS's decision to move it away from being a universal vaccination, it used to be where the vaccine was given to all children 12 to 24 hours from when they were born. Overall, this has been considered a successful public health policy. The vaccine itself is between 90 and 95% efficacious. It has greatly brought down the numbers of cases in the pediatric population over the last 20 years. Before universal vaccination, there was an estimated, CDC said about 18,000 children a year contracted the virus, 18,000 per year. And that number has fallen to fewer than 1,000 children or adolescents annually getting it. And, more recently, getting back to what we were saying before about the dropping vaccination rates, really, you would say almost across the board we're seeing this. But more recently, a study showed a peak immunization of the universal birth dose of hepatitis B was at 83% in 2023. So just a couple years ago.
Yeah.
And then 2 years later in 2025, so just last year, within 2 years, it had dropped 10% to 73% in terms of the immunization rate. So we're seeing this quickly unfolding. Yeah. And that's the thing that I think is scariest because, again, the ripple effect it'll have on generations is not yet felt. And nobody will really know how bad it is until potentially decades from now.
Just wait till our hands are full, really, with all these public health crises from infectious disease that has just been untethered, unfortunately. It's a very morbid thought and concerning all the same, but I appreciate everything you do to cover it and help inform folks and put responsible experts on Contagion to allow, the dissemination of the right information, the right actions that they can take. Glad we could share some of it today. And I always like just catching up with you, man. Even though it's scary stuff we're talking about sometimes, it's always fun catching up.
Right. And the one thing I'll say too is we had the best of American medical science and innovation in 2020 and 2021. Yeah. And here's hoping we'll have a course correction at some point, and then we'll get back to where we were with the innovation. I mean, if you think about it, and you and I have had many conversations about the idea that within less than a year, they were able to map it out and create successful COVID-19 vaccines in less than a year. That's unheard of.
Necessity breeds innovation, and I think that was one of the finer examples of it from the American health system, the way we were able to supply the world with the right product at the right time to, prevent further, demise from COVID was a huge relief and a very fascinating development that I'd love to get back into if we come back onto the show. So thank you again, John. I really appreciate it. That's all we're going to be hearing from John right now. And let's go over to my interview with Dr. Hopkins now. So I wanted to start with a little more context with you, if you didn't mind, to ask you, historically, what level of evidence has ACIP required before changing vaccine recommendations as is occurring right now?
Well, ACIP traditionally has used a lot of active surveillance systems that get data input from the states, all delivered to CDC for broad strokes. They also have a number of surveillance systems looking at rates of influenza disease, outpatient visits, emergency department visits, hospitalizations, looking at disease surveillance like measles, like pertussis. And so those surveillance systems provide, what's the clinical impact of these vaccine preventable diseases or diseases that we need to be aware of. They then have data on what the vaccines that are going to be considered. Safety data, effectiveness data, utilization data. They would have data on, are there concerns about uptake? What are the clinicians see? Is this something that's going to have a challenge with implementation? So they'd take basically all of those pieces, put it into a process called GRADE. GRADE is a structured evaluation process to look at all of those pieces of data and lead to a recommendation that's based on those multiple different pieces of information that really give you the practical underpinnings of, is this something that can be done, should be done to protect the American public?
As you alluded to, risk of measles outbreak already occurring, of course, in the country has been since last year. We had an update back in January to talk about sort of this historical trend relative to more recent numbers, of course, since our very successful mitigation strategies from decades ago, becoming quite a bit untethered, unfortunately, in that regard. How does that context of the measles outbreak that's occurring right now influence the stakes of the ACIP decision making that's going to be occurring now?
I see a couple of pieces to it. One is, it truly is shocking to me that this current ACIP has not had a single discussion about measles and what's happening on measles in the United States to this point. That's a historic absence. So I think that that lack of attention to that problem is a big problem from my perspective for clinicians and for the public to know how important this is in the context of the immunization landscape. Second is, reductions in immunization rates happen when people have questions, when people have uncertainty. You know, if you're uncertain about something, we're much more likely to be stagnant, to not do something. And so I think the lack of attention there has probably played into a degree to our reduction in immunization rates, which has allowed the most contagious virus we know about to continue to spread in particularly communities and populations who are unvaccinated and undervaccinated. That's a big problem.
For sure.
And it's, it's the tip of the iceberg, or the sprinkles on top of the ice cream, as you may call it.
Very unfortunate, but yes, no, rather really the case. Of course, as you alluded to before, we're operating without an agenda, and that was a big topic of discussion for John and I as well when we were reviewing exactly what to expect. Who knows what to expect? We're not working with much nuance, and we talked a little bit about the recalibration of the CDC leadership under Dr. Bhattacharya, and of course, the addition of two more panel members, sort of adding again to the element of the unknown. What are we exactly getting here? Is it more of a reiteration of Robert F. Kennedy Jr.'s sentiments and overarching strategies of the HHS? Is this a return to, scientific evidence from the more traditional standards? Where are we going to meet on Wednesday is a huge question mark. But there's, of course, a lot of expectation that the crux of conversation is going to hook around COVID-19 vaccine safety and injury reporting. Is that fair to assume?
Based on what's been posted on the Federal Register, the things that were listed are updates on the ACIP work groups. We know to date that not a lot of work group activity has been going on, or at least there's evidence that that's been going on since this new committee has happened. And really, historically, the work of the work groups has driven the presentations to the ACIP meeting.
Right.
Those work groups, go through these reams of data in order for there to be thoughtful presentations to the committee for votes. So
Right.
updates on ACIP work groups. They posted discussions on COVID-19 vaccine injuries and long COVID. Hard to know what they're going to be discussing. We know that there's lots of data out there that shows that these vaccines do not cause any common safety events. Yes, there are some uncommon cases of myocarditis, but those have been much less common since 2023. No other common serious safety events. We know long COVID is a problem. There's still some challenges with definitions. We don't have really enough data to know what all we should call long COVID, and really, more importantly, what to do about all the myriad of different things that follow COVID infections. They've announced there's going to be a discussion on ACIP recommendation methodology. Are we going to blow up this previous structured evidence presentation process, what's important, and the evaluation? And then it says on the announcement, recommendation votes may be scheduled around COVID-19 vaccine injuries, long COVID, and ACIP recommendation methodology. If you read the ACIP charter, there's nothing in the ACIP charter about long COVID. Nothing in the ACIP charter about making definitions for disease processes.
Right.
COVID-19 vaccine injuries are a concern of the committee, but what they're going to discuss is hard to say. And
It
this is
is
in the context,
Yeah.
and this is in the context of we've got 4 new members of the committee since the last meeting. 2 obstetrician gynecologists, both who are on the record for many statements against vaccination in pregnancies and specifically against COVID-19 vaccination in pregnancy, citing safety concerns. A new pediatrician who's been a member of a group that's been very active against COVID-19 vaccines, the American Frontline Doctors, and another who's an experienced concierge internal medicine pediatrics physician in Florida who I can't find any evidence of experience in vaccine science. So it's a bit of a hard to know what we're going to expect out of this meeting.
I think it's also good timing to maybe, reiterate to your colleagues and peers, of course, the standards and methodology behind vaccine safety reporting, because I know this was a crux of conversation during the rollout of COVID vaccines and understanding both, I guess, the wide arching capability to report, but also the finer standards by the CDC and other institutions to refine those data, and actually come to informed decisions about what's actually being reported out in the field. Can you explain that for us?
Sure. We've got multiple vaccine safety systems that are in place for monitoring of all vaccines, not just one, not just 2, but all of them. The first one is the Vaccine Adverse Events Reporting System, or VAERS, that most people have heard about to this point. VAERS is a passive reporting system. You can report, I can report, anybody who knows about a potential vaccine injury can report on the web or by a paper form. That information is basically hypothesis generating. You cannot determine causality for those vaccine reports because you don't have the level of detail needed to do that or the context about the individual. That is what generates hypotheses that can then be evaluated in more robust systems like the Vaccine Safety Data Link, which links vaccination records with clinical records in integrated health information systems that allow us to determine, is this something that was present before the vaccination? Does the timing fit? Does the chain of evidence support this event linked? Or some of the FDA systems, including a system called BEST, or others that can take large, claims databases managed by Medicare and drill down to that information and try to come to better evidence that there is a linkage or not. So there are much better systems in VAERS to ferret this out as truly is this causally related or not. But
Right.
VAERS is to generate hypotheses, and making conclusions based on VAERS alone is really taking a lot of leaps of steps of evidence.
Yes, unfortunately, this is something I think we saw in early iterations, like I alluded to, from the initial rollout of people pointing to the VAERS, the publicly available data coming from VAERS as evidence, supporting their claims, against the overall safety and effectiveness of the vaccines. But again, as you're describing, there's such finer systems in place to find and retool that. It kind of reminds me as well of the same thing we were dealing with in the pandemic was the widespread popularity of non-peer-reviewed, journal databases as people, again, the exposure of the general public, I guess I would say, to the academic process and rigors of pharmacological monitoring, surveillance, and development really, I think, helped catalyze where we are right now, where it is like come into, as so many people have, defined it, into a legitimate space of rhetoric against, the traditional methods. And that's where we see this conflict that's going to really occur, it feels, at the ACIP meeting in just a few days. Is there anything else that you sort of observe as a trend in that regard of that really heightens your concern as an infectious disease specialist and expert?
Well, it's really just going to be the question of how and what's going to be presented, and is there going to be the opportunity for the liaison representatives, the representatives of other organizations in the healthcare system, is there going to be the opportunity for them to comment? Are CDC content experts going to be able to provide presentations or answer questions? Or is this going to be simply a series of presentations by people who've got preconceived notions? That's really going to be the question going in. I'm a primary care internal medicine and pediatrics doctor. I'm not an infectious disease specialist, but I've spent a lot of time working in the vaccine space for the totality of my career. And we're in a new world when it comes to the current ACIP. I can understand people wanting we're Americans. We want an answer now or yesterday. And, quick answers, something that's potentially inexpensive and, and fast, and you find something that suggests it may work. People oftentimes are going to latch onto that for particularly when there's not good, easily accessible answers. We've got to be a little more cautious when it comes to the health of us and our families and our communities, and really make sure that we're following that trail of evidence from A to B to C to D. You got to follow those breadcrumbs. You can't just jump from A to F and expect that you know what you're doing.
If we could talk, unfortunately, a little bit about the implications of those inactions by individuals to keep their family, loved ones, neighbors, community safer with vaccination. What really stands out to you, especially from your perspective? And thank you for, of course, correcting me before about your specialty of focus. What exactly stands out to you as a very heightened concern of this may recur? We're dealing with measles outbreak, but next week it may be this.
Well, I think it comes down to we've got to get back to the art of face-to-face conversations. We need to put reliable information out. We need to answer people's questions one-on-one. We need to be willing and able and committed to, if you don't know, saying, I don't know. But if it's a question there's an answer for, say, I don't know, but let's do what we can to find this information, to find this answer for. If we can have those mutually respectful conversations between patients, family members, healthcare professionals, we're going to get through this. Along with, this is false, or this is truly backed by these studies. We've got to do all of those pieces, some on the micro level, some on the macro level. But I think face-to-face conversations in a mutually respectful way are the only way we're going to get out of this.
I try to tell folks we don't have to agree. We just have to understand where we're coming from. And that's really the crux of conversation of understand and the place.
Shared motivation.
Yeah.
Motivation. I want you and your family to be healthy. What can we do to get you there?
Exactly. We're all coming from the same place and striving toward the same goal. So, it's easier to reverse engineer from there. Curious to ask you to that sentiment as well of like these trends and consistencies and patterns in the rhetoric against, vaccine safety, risk of injury relative to their overall benefit to not just the individual, but the global population. Are there any patterns, trends? I'd almost want to say like non-overt messaging that perks your ears when you hear it in these discussions that may occur in ACIP that you would want to flag to your clinicians, peers, or even just your patients as like, when you hear this, that's a clear sign that you're going down a path that you maybe need to course correct or reconsider your resources.
So I would first think about any time an assertion is made without linkage to science or without linkage to a study. If somebody says this is in VAERS and there's not support from one of the U.S. Systems that are designed to evaluate this further, BSD, BEST, or others, or one of our international partners systems. The Nordic countries all have very robust vaccine safety evaluation systems. The European Union has some very robust systems. The Israelis have some very robust systems. If we're getting assertions based on, case reports, cases out of VAERS alone, without that other support, or you're making allegations of causality out of VAERS without validation in a more robust system, that's a red flag. If you have somebody making a presentation that doesn't have scientific background, if you have somebody that, may be an MBA or a lawyer or some other professional, even potentially, that's not somebody that's in medicine or has a scientific background. That to me is a red flag. Doesn't mean it's not true, but it at least raises the question. Is this person expert enough to make these analyses? If we're not seeing presentations by CDC scientific content experts, if we're not seeing presentations by people with the background to make them, you have to raise questions.
Staying a bit realistic, of course, this trend has occurred. And as we're describing with the measles outbreak and again, our continued strain to mitigate previously mitigated, outbreaks, the reality is that this is something we're going to be adjusting to in some kind of capacity. John and I described the reality that even if we were able to, close Pandora's box today, and we made a resolve to get back to our standards and strategies for, protection through vaccines for a lot of these outbreak risks, we're going to be living in a different future for quite a bit, just from the cascading effects. What may that look like in reality for the population?
Well, I'm gonna answer you slightly off from what you asked.
That's fine.
I want to start with the fact that we have seen in the last couple of 3 weeks that the number of measles cases in South Carolina have come down pretty dramatically.
Good.
Seen at least some. I haven't seen the data, but I've seen some hints that vaccination rates for measles in particular, measles, mumps, rubella, in the Carolinas are going up. So there is hope. With the right kind of interventions, we can get there. But if we don't make outreaches to communities that may not necessarily trust in healthcare, may not necessarily trust in others, if we're not talking to their community leaders, if we're not reaching out to people that may think differently than I may think, if we're not, again, trying to make those outreaches now, we're going to continue to have communities or populations within our communities that are under-vaccinated. We're going to continue to see measles. We've started seeing some pop-ups of mumps cases in areas with low vaccination rates. Pertussis is going to continue to circulate. What I don't want to see is us having some imported cases of polio, or see us having other vaccine-preventable diseases reemerge in this country. We've got to make sure that we're reaching people where they are, we're having conversations focused on shared values, that we're working together to solve these problems without any finger pointing, without any blame casting. It really comes down to meeting people where they are and having those conversations, but it's got to be at the micro level as much as at the town, the city, the neighborhood level. And that means, we've got to also talk with our legislators. We've got to talk with our school boards. We have to talk with others so that at all levels, we're having those conversations to try to understand where people are, to try to reach that common goal of protecting communities.